Good afternoon, everyone, and thank you for joining in. I'm Dr. Vikram Mukherjee, Director of the Special Pathogens Program and Chief of Critical Care at New York City Health and Hospitals Bellevue Hospital, and co-PI for the National Emerging Special Pathogens Training and Education Center, or NETEC. It's an absolute privilege to help moderate today's important discussion. We meet at a pivotal time. The Democratic Republic of the Congo is confronting its 16th Ebola outbreak, declared on September 4th. As of October, there have been at least 64 confirmed or probable cases, including 45 deaths. While this outbreak is unfolding thousands of miles away, the implications are very real for us here in the United States. Every Ebola event reminds us that global outbreaks can quickly become threats to US biosecurity, to the safety of our healthcare workforce, and to the health of our communities. That's why the ability to respond, not just prepare, is so vital. The deep collaborations between ASPR and CDC lies at the heart of this national response system. Together, our agencies ensure that US hospitals can identify, isolate, and manage suspected Ebola cases safely and effectively while keeping our healthcare workers protected. That partnership between federal agencies, public health, and healthcare delivery is what strengthens our national resilience. Today, you'll hear from CDC experts about the current situation in the DRC, clinical management of Ebola, and infection prevention and control. You'll also hear from NETEC experts how NETEC continues to serve as a national resource, providing training, education, and coordination to ensure that we are ready to deliver safe, specialized care whenever and wherever it's needed. Thank you for the work each of you do every day to safeguard your patients, your colleagues, and your communities. With that, let's begin. We have a rich list of speakers and panelists today. Our overview here is as follows. We have Dr. Barbara Nakanust describing the current status of the Ebola disease and outbreak in the DRC. We have Captain Ryan Fagan describing infection prevention and control for VHFs in US healthcare settings. And we have Dr. Anish Mehta talking about the NETEC and the NSPS as a partnership in preparedness for the United States. So our first speaker, next please, Benjamin, is Dr. Barbara Knust. She is a veterinary epidemiologist with 16 years of experience at the CDC. She has led multiple outbreak responses of viral hemorrhagic fevers, including Ebola, Marburg, and Lassa, as a subject matter expert in CDC's Viral Special Pathogens branch. She has also worked on migration health in CDC's Thailand country office. She currently is a senior scientist at CDC's One Health office at the National Center for Emerging and Zoonotic Infectious Diseases. With that, thank you, Barbara. Over to you.
Thanks very much, and good afternoon, everyone. For my section of this presentation, I will focus on giving a brief update of the current outbreak, an overview of Ebola disease features, discuss diagnosis and other infections that can be confused for Ebola, and I'll touch briefly on vaccine therapeutics and the benefit of clinical consultation with CDC. So for the timeline for the current outbreak in Democratic Republic of Congo, or DRC, on August 14th, a pregnant woman was hospitalized in Kasai province with a progressive illness and died 5 days later with hemorrhagic symptoms and multi-organ failure. This initiated an investigation within DRC's Ministry of Health, which eventually led to CDC being notified on September 1st of a suspected viral hemorrhagic fever outbreak. The national lab confirmed the patient's illness was caused by Ebola virus on September 3rd, and national notifications followed, and CDC established an emergency response structure to respond to the outbreak on September 5th. More than a month and a half has passed since that time, and here's the current situation. As of this week, the total number of cases stands at 64. 53 were laboratory confirmed and 11 were probable cases who died without laboratory confirmation. 45 total confirmed and probable cases died, for a 70% case fatality rate. The last patient to be confirmed was on September 26th, and the last patient was discharged this week from the Ebola Treatment Center. Also, all of the nearly 2,000 identified contacts have now completed their 21-day follow-up period. Vaccination of high-risk persons started by the end of September, with more than 36,000 persons vaccinated to date. This was done in a ring approach where high-risk contacts of confirmed cases in their communities were offered vaccines, as well as healthcare workers and other persons with increased exposure risk. In parallel, vaccine was also offered to the general eligible population in affected geographic areas. One factor that has been both a challenge for accessing the outbreak zone and potentially a factor in limiting the spread is that it is located in a very remote and rural area. Risk of spread beyond the Kasai province is considered to be low due to a sparse network of poor quality roads. This inaccessibility has meant that deployers have struggled to reach areas where patients and contacts were located, and so we may not necessarily know the true scope of the outbreak in this remote area. Despite its location, it still remains of utmost importance to control the outbreak so it does not reach other areas of DRC or beyond the country. DRC is a country that has experienced many outbreaks of Ebola in the past. The very first outbreak where Ebola virus was discovered was in what is now called DRC in 1976, and this is the 16th outbreak to occur there. The location of the outbreak in Kasai province in the central part of DRC has also had Ebola outbreaks previously in 2007 and 2008. The specific affected health zone within Kasai province is highlighted on this map in red in the northeastern part of the province. Ebola disease, previously referred to as Ebola virus disease or Ebola hemorrhagic fever, is a serious illness that has a high fatality rate. A patient's chance of survival increases if they receive treatment quickly. Despite the well-known hemorrhagic symptoms, these are only reported in half or fewer of patients. Hemorrhagic symptoms typically present after several days of illness and clinical progression of disease. Common initial symptoms include fever, headache, muscle and joint pain, fatigue, loss of appetite, and gastrointestinal symptoms. Clinical progression can include multi-organ failure and neurologic symptoms. There are multiple species in the filovirus family, which includes both Ebola and Marburg viruses in their respective genuses. The causative agent of this current outbreak is orthoebolavirus xyrense, commonly known as Ebola virus. This is the same virus species as what was discovered in DRC in 1976. Regarding Ebola transmission, the virus spreads through direct contact with blood or body fluids of infected persons or animals. This can be from contact with an infected person, contact with their contaminated body fluids, or with contaminated objects such as needles. People who have recovered from acute Ebola disease can also harbor virus in their body. Relapse of infection can occur where a recovered person becomes ill again, and people can become exposed. Also, body fluids, such as semen and breast milk, can have virus persist even in a person who is apparently healthy following recovery. Programs are in place to provide testing and counseling for people who have recovered from Ebola virus infection to ensure they receive care and risk reduction support. Ebola virus is zoonotic, and outbreaks are initiated through a spillover event following contact with an infected animal. Primates, bats, and other mammals can be infected. So for clinicians, it is important to consider the patient's clinical picture, their travel history, and potential risk factors together. Given that Ebola disease can have vague initial symptoms, gathering a thorough travel history is very important. The country, dates, and specific regions that a patient has traveled to are all key pieces of information. Also important to consider is whether the patient has had any of these specific risk factors. So Ebola disease should be included in the differential for an ill traveler who has been to the outbreak zone, has compatible clinical symptoms, and one or more of the risk factors in the 21 days before their illness onset. However, we want to emphasize that the most likely and common cause of undifferentiated fever after travel to sub-Saharan Africa is malaria. Nearly all of the signs and symptoms of Ebola disease can also be seen in malaria. Infections caused by Plasmodium falciparum are serious and can progress rapidly, with early diagnosis and treatment a key to survival. Testing should not be delayed. In addition to the travel history and Ebola-related risk factors, you should also ask the patient about whether they used malaria prophylaxis and adhered to it during their travels. Further, a history of taking malaria prophylaxis does not exclude malaria infection. Bottom line, all febrile travelers who recently arrived from DRC should be tested for malaria. If you are concerned your patient may have Ebola disease, you should first contact your state or local health department and follow their protocols for patient assessment. In advance, ensure that you can identify points of contact and contact information for your health departments, including their on-call information. CDC's Emergency Operations Center can also assist in finding contact information for state and large jurisdictional health departments. As a resource for public health departments, CDC's Viral Special Pathogens branch is available 24/7 for consultations. This service is not affected by the government shutdown. So Ebola vaccine is now available. Briefly, the vaccine is a recombinant vesicular stomatitis virus with the Ebola virus glycoprotein added. The trade name is Ervebo, and it is the only FDA-approved Ebola vaccine in a single-dose regimen. The vaccine has some side effects relating to fever and headache, and vaccine recipients may test PCR positive for about a week for the glycoprotein, but not for other RNA targets for Ebola. Vaccine is given to people at risk of infection and is not effective to use as a treatment for persons who have already developed infection. Also, the vaccine does not carry Ebola virus and cannot transmit the virus. The vaccine has efficacy estimated between 84 to 97% in prevention of infections and a reduction in fatality to 25% among vaccinated persons who develop infection. During this outbreak, DRC's government made vaccination a requirement for all deployers traveling to the outbreak area. Last month, there was a NETEC webinar that covered more specifics about the vaccine and how to access it through the Strategic National Stockpile. For more information, please refer to that recording. There are 2 FDA-approved treatments available for Ebola disease, both which are monoclonal antibodies given through a single IV infusion. Inmazeb is a cocktail of 3 monoclonal antibodies, while Ebanga is a single moiety. Both treatments have proven effective in improving patient survival, although early treatment is an important factor. Supportive care can also significantly improve a patient's chances of survival when started early in the illness progression. Okay, so let's talk a little bit more about what CDC can offer in terms of clinical consultation. Through our Emergency Operations Center line, you can connect directly with subject matter experts in viral hemorrhagic fevers. They will ask about the patient's travel history, epidemiologic risk factors, clinical course, diagnostic tests performed, and infection control measures in place. Based on all of this information, a collective decision will be reached about whether testing is recommended. However, the final decision to proceed with testing rests with the treating physician. Once the decision to test is made, everyone will work together to arrange for shipping and testing of the specimen. Specific details of testing can vary depending on whether there is an LRN laboratory with viral hemorrhagic fever testing capabilities. Shipping logistics can also vary. There are several benefits to performing clinical consultation with CDC in coordination with the clinician and the state or local public health authority. CDC has the most up-to-date information on the outbreak's geographic extent, which may be unavailable from public reports. This can provide context to the patient's epidemiologic risk factors and clinical signs, especially considering that the clinical picture is often vague. CDC can assist with the process also to coordinate testing and shipment of specimens and serves as the confirmatory laboratory for any presumptive positive results in the United States. As such, ensuring awareness of suspected VHF early in the process can help with prompt confirmation and response support. In the event the healthcare facility does not have the capacity to care for the suspect Ebola patient, CDC can also facilitate discussions to arrange transport to an alternate healthcare facility.
Wonderful. Thank you, Barbara. Wonderful talk. We will now move on to Captain Ryan Fagan. Ryan is captain of the U.S. Public Health Services and is the Domestic Healthcare Infection Prevention and Control 2025 Ebola response. He has 14 years of professional experience in public health support to healthcare infection prevention and control activities in U.S. healthcare facilities. He has contributed to multiple U.S. and international viral hemorrhagic fever responses. Thank you. Ryan, over to you.
Thank you for the introduction. Next slide, please. So my overview will include the Identify, Isolate, Inform framework, Some considerations about PPE and other precautions for viral hemorrhagic fevers. A new CDC listserv for organizations that send US-based personnel to work overseas, and CDC support to health departments for healthcare worker risk assessment and monitoring. The VHF guidance is organized under headings for healthcare providers and public health professionals. Some screenshots shown here. Some of these documents are relevant to both groups. The current IPC recommendations for Ebola are similar to what was developed during the 2014 to 2016 Ebola response. However, in 2024, that guidance was reframed to also include Marburg, Lassa, Crimean Congo hemorrhagic fever, and several South American hemorrhagic fevers. These changes were presented to the Healthcare Infection Control Practices Advisory Committee and posted to the Federal Register for comment before finalizing. This IPC guidance is intended for all U.S. healthcare personnel, including emergency services and medical transport, though some topics are more relevant to hospital settings. Moving on to the Identify, Isolate, Inform framework. The Identify part is about having a process to screen for contagious illnesses at initial points of patient encounter. Early recognition helps prevent unprotected exposures to healthcare personnel, visitors, and other patients. This concept does extend beyond just viral hemorrhagic fevers. Early VHF symptoms are nonspecific, and a travel history is a key part of understanding the patient's risk of having VHF. A single best screening approach has not been defined in our guidance. However, we've heard that some hospital systems are beginning to use electronic medical record systems to improve the consistency of capture of that information and accessibility of that information to staff. And recently, the Joint Commission has phased in new requirements for U.S. hospitals to have a process to screen for respiratory symptoms, fever, rash, and travel history. These requirements are intended to strengthen basic infection control processes for routine and non-special pathogen infectious agents, as well as high-consequence pathogens like VHFs. For isolate, if VHF is suspected based on symptoms, travel from an outbreak area, or other risk factors such as exposure to an infected person, the patient should be isolated in a single room with the door kept closed. The room should have a private bathroom or a bedside commode. And if the patient is unstable and might undergo aerosol generating procedures such as intubation or open suction of airways, ideally they should be placed in an airborne infection isolation room if feasible. Adequate space for putting on or donning and taking off or doffing PPE should also be available. Healthcare facilities should have processes already in place for informing key staff and public health authorities when VHF is suspected. CSTE, the Council for State and Territorial Epidemiologists, maintains a list of regular and after-hours phone numbers for healthcare providers to use to contact their health department. And the CDC Emergency Operations Center is available to support health departments 24/7. We understand that most people with fever and recent travel from a VHF-prone area end up having something besides VHF, like malaria or influenza, or in a recent example, measles. Timely public health consultation helps inform the differential diagnosis, the need for continued VHF infection control precautions, and potential public health support for testing or deployment of other resources. CDC's PPE guidance for viral hemorrhagic fevers addresses two main scenarios. One PPE ensemble is for a patient with suspected VHF who is clinically stable, not having bleeding, vomiting, or diarrhea. This ensemble is sometimes referred to as dry and suspect PPE. The other ensemble is recommended when greater exposure to blood or body fluids is anticipated, including a patient with confirmed VHF or a patient with suspected VHF who is having bleeding, vomiting, or diarrhea, is unstable, or will require invasive or aerosol generating procedures. This ensemble is sometimes referred to as wet or confirmed PPE. Please refer to the guidance and the frequently asked questions for specifics about PPE selection, donning, use, doffing, and the role of trained observers and doffing assistants. NETEC has many PPE resources on their website, including guides with helpful pictures and videos. Likewise, PPE training videos developed by CDC and partners in 2014 are still available online. CDC has a new listserv for U.S. organizations that send healthcare personnel to VHF outbreak-prone areas. Such personnel might not anticipate the possibility of being caught up in a VHF outbreak during their travel. When a new outbreak is confirmed, CDC will email subscribers with information to support their health and safety, including links to guidance about symptom screening, exposure assessments, travel and return to work guidance, and how to engage local health departments and CDC about potential exposures. To sign up for the VHF Healthcare Listserv, go to the link on this slide, enter your email address, click register, and follow the instructions. And in U.S. healthcare settings, health departments and CDC support assessment of healthcare personnel who are potentially exposed while caring for a VHF patient, including when VHF is not initially suspected during clinical care. It is urgent to identify exposed healthcare personnel who warrant post-exposure prophylaxis, work restrictions, and monitoring. And a localized plan is needed for how to manage healthcare personnel who become symptomatic during their monitoring period. Exposure assessment and monitoring can be challenging. Some cases have involved 100 or more potentially exposed healthcare personnel across multiple facilities and EMS groups. Public health support to occupational health departments is often needed. Many states have developed tools to support assessment and monitoring of persons, such as return travelers and healthcare personnel working in U.S. healthcare facilities. CDC worked with several states with existing REDCap tools to develop an updated template to support exposure assessment and monitoring of healthcare personnel in a VHF scenario. These files have already been shared with all U.S. state healthcare associated infection programs. Also, this template was adapted and used in Iowa for the 2024 LASA response. CDC is currently planning updates to the tool to include general community and laboratory exposures. And as a footnote, we know that REDCap isn't going to be the preferred tool for all jurisdictions, but we started there because it's commonly used for this purpose, and it's a relatively flexible platform for being able to share templates and make updates locally. On to a few points about environmental infection control for VHFs. Healthcare personnel who perform cleaning and disinfection should be properly trained and protected. And remember to ask about your environmental services workers when vetting potentially exposed groups of healthcare personnel. See EPA's website for lists of disinfectants that are recommended for viral hemorrhagic fevers and other other emerging viral pathogens. And avoid contamination of porous surfaces that cannot be made single use. Finally, VHF contaminated linens and other textiles should be discarded. A conversation with your waste management company is advised before discarding items that are different than are normally disposed of, including large items such as mattresses or furniture. CDC provides general recommendations about handling of VHF-associated solid waste, liquid waste, such as body fluids, including blood, urine, vomit, or feces, and spills within healthcare settings. But CDC is not the regulatory authority for waste management. Healthcare facilities must comply with applicable federal, state, and local regulations for handling, storage, treatment, and disposal of VHF-associated waste. In the U.S., Ebola, Marburg, Lassa, and other specified VHFs are designated as Category A infectious substances. The U.S. Department of Transportation manages the U.S. guidance for managing Category A solid waste. Appendix F1 includes the special requirements for permitting, packaging, transporting, and the rest of the management considerations for waste contaminated with Ebola and Marburg virus. One thing that we've seen in our clinical consultations during the period of diagnostic evaluation of a patient with suspected VHF, it may be appropriate and preferable to temporarily hold waste in a secure location at the facility. If VHF is ruled out, the waste can then be managed according to local practices. The Environmental Protection Agency and partners support an online state-by-state regulated medical waste resource locator. Clicking on the map gives a view of contacts and resources for the selected state. And shown here is the Category A guidance that I mentioned on the prior slide. Now, hopefully you won't need to use this particular guidance, but several U.S. hospitals have had to manage the remains of patients who died of VHS while hospitalized, including Ebola and Lassa fever. Recommendations include avoiding removal of inserted medical equipment, avoiding autopsy unless absolutely necessary and in consultation with public health, and use of body bags. This guidance also extends beyond the healthcare setting to include transport, mortuary care, and final disposition of the body. That is the end of my section of the presentation, and this page summarizes some of the key guidance links. Thank you.
Perfect. Well, thank you, Captain Fagan. Wonderful talk there, and thank you for all of that. So, Doctor, it's my privilege and honor to introduce Dr. Anish Mehta. Anish is a professor of medicine at the Emory University School of Medicine and also serves as the Chief of Infectious Disease Services at Emory University Hospital. Anish has been one of the core physicians of the Emory Serious Communicable Diseases Unit, SCDU, since 2009. He was the admitting physician for the first patient with Ebola virus disease cared for in the US and was highly involved in care of the 4 patients with EBD, 1 patient with Lassa fever, and several POIs cared for by the Emory SCDU. Anish is a co-PI at NETEC and co-principal investigator of Emory's NIH Center for Excellence in Influenza Research and Response. So thank you, Anish. Over to you.
Thank you, Dr. Mukherjee, for that very kind introduction, and I'm very honored to be here. Really enjoyed the talks by Dr. Knust and Dr. Fagan, and very honored to speak on behalf of NETEC and NSPS, talking about our partnership to prepare and respond with healthcare facilities in the United States. Next slide, please. So NETEC, or the National Emerging Special Pathogen Training and Education Center, has been funded by ASPR since 2015 to set the gold standard for special pathogen preparedness and response across healthcare systems in the United States. Our origin story actually goes back to an unfortunate domestic cluster of Ebola cases in Dallas in 2014. And it was recognized by HHS, ASPR, and CDC that healthcare systems needed better preparedness for these special pathogen events. They reached out to the 3 hospitals, civilian non-government hospitals that had cared for patients with Ebola and asked us to develop this system. So that is Emory University, University of Nebraska Medical Center, and Bellevue Hospital, part of NYC Health and Hospitals. In 2023, after 2 years of development with ASPR, NETEC was asked by Congress to serve as the NSPS coordinating body to establish this robust network, integrated network of hospitals for special pathogen preparedness emergencies. Next slide, please. Our core areas of focus are education and training, consultation and assessment, special pathogens research network, and our international partnerships and programs. We are very honored to partner with our now 13 NSPS Level 1 sites, otherwise known as Regional Emerging Special Pathogens Treatment Centers, or RESPECTs for short. They are distributed in all 10 HHS regions, and you can see the list of our wonderful partners here on the right. So now let's get into what is the NSPS and the system that we're developing. It is a tiered system of care with levels 1 through 4, which have variable capabilities of care for suspect or confirmed patients with high consequence infectious disease, or HCIDs. It's based similarly to the trauma network and the burn network. We used a lot of their guidance to develop this system. Next slide, please. So our core mission is to develop a coordinated network of high quality special pathogen care dedicated to protecting patients, our communities, and the healthcare workforce across the United States. And we envision to save lives and protect the healthcare workforce through this agile and comprehensive special pathogen system of care. Our aspirational goals as we launch is to have 0 preventable deaths after a special pathogen infection, have a network mobilization within 2 hours of a suspect case, and importantly, have 100% of Americans have access to high quality special pathogen care when needed. This is our tiered system. The foundation is our level 4 facilities. These are all healthcare facilities in the United States that are asked to and have programs to rapidly identify, isolate, and inform when there is a suspected special pathogen case, and also initialize stabilizing medical care in a way that protects their staff and other community members. The next level are our level 3 facilities. These are our assessment centers. These are centers that would be able to take in patients with suspect cases and do basic laboratory testing, coordinate with public health to get diagnostic testing to the appropriate site, and then coordinate, if needed, rapid transfer of the patient to a level 2 or level 1 facility. Level 2 facilities are our special pathogen treatment centers. They have the ability to deliver specialized care to a cluster of patients with HCIDs and provide care for them during the duration of their illness. Level 1 facilities, also known as RESPECTs, as I mentioned before, will have the ability to do the same, everything that a level 2 facility will, but will have the additional requirements of being the regional resource hubs for the entire region, and also provide highly specialized care, such as things like ECMO and delivery of babies from mothers with special pathogens. Really important for this all to work are our EMS partners. We cannot get patients to the appropriate level of care, the setting of care, without wonderfully trained and integrated EMS partners. All of this network requires also coordination and partnership with our public health authorities. And we've seen amazing engagement throughout ASPR, throughout CDC, and very importantly, in our state and jurisdictional public health departments. These are the domains that NETEC and the RESPECTs support within our NSPS network. They very much match the same domains that our CDC colleagues just described in their presentations. So now I'm going to talk a little bit about our NETEC and NSPS response in this current Ebola outbreak. I will also mention this is very similar to the things that we did with the Lhasa outbreak that occurred in Iowa that Dr. Fagan mentioned in his presentation. So on September 2nd, NETEC leadership was informed by our public health partners, both here in the US and in the DRC, of possible cases of Ebola that were occurring in the DRC. We rapidly reached out to our ASPR and CDC liaisons to confirm that they were hearing similar concerns, and they did confirm this. And the confirmation that this was Ebola virus disease came on September 3rd, as mentioned by our CDC partners. We then rapidly informed our level 1 RESPECT partners for the need to prepare their hospitals and their regions for potential Ebola cases, even though the risk at that moment was low. We also started to gather data. We assessed our level 1 RESPECT facilities and their regional assets to see if there were any support needs at that moment. Again, going on our well-established partnership with public health colleagues, we wanted to understand where returning travelers from the DRC typically enter the United States and where their final destinations may be, because that allowed us to really prioritize assets and preparations in those areas. And one of many other things that we did, we have a wonderful working relationship with EMR vendors across the United States, in particular Epic, and we were able to rapidly work with the Epic team to update the travel screen to include returning travelers from the DRC. So I also want to talk about our wonderful RESPECT partners and how quickly they can respond. So here you can see 2 examples of our RESPECTs very quickly putting out information about what was going on. And you can see an example from Emory. And on the right side, you can see an example from our partners at Bellevue Hospital putting out a update to their website very quickly to share tools and training capabilities and basic information for their region. So NETEC has continued to assess and update our online resources for Ebola for NSPS facilities, but really all hospitals in the United States, and very importantly for every healthcare worker who's interested. So here you can see our main web page with our Ebola landing page. Next slide, please. And so this is just an overview of what we do every time there's a new outbreak. We put out information on where healthcare workers and hospitals can start, and then we select specific resources, such as our healthcare facility special pathogen preparedness checklist, identify, isolate, and inform tip sheets, and many other these assets to make them readily available and importantly, able to be delivered and used in the local context of American hospitals. This is one of the assets that I really like to describe that our consultation and assessment team have put together. This is our healthcare facility viral hemorrhagic fever preparedness checklist, where we go through all the areas that Dr. Fagan talked about earlier: identify, isolate, inform, personal protective equipment, treatment and care, as well as waste management and cleaning and disinfection. In these documents, you will see really easy to deploy checklists that help our healthcare workers and our administrative staff in hospitals really assess where they are in their preparedness and readiness to respond, and be able to really quickly move forward to a response structure when needed. So another wonderful thing that I feel that we do is our clinician-to-clinician consultations. We have a cadre of SMEs that are drawn up from our level 1 respects, as well as domestic and international partners. Very importantly, this includes amazing nurses who have done this work, physicians and providers, but I particularly highlight our nursing colleagues. They're the ones on the front line at the bedside every moment of patient care for these special pathogens. And they're the ones that are very readily preparing in the emergency rooms and our ICUs, as well as throughout our hospitals for these patients. We can put them in contact with like colleagues, like nurses who have done this work that can talk them through the processes. We have people who specialize in emergency medicine, pediatrics, infectious disease, critical care, hospital medicine. We also have wonderful SMEs in our emergency medical services, paramedics and EMTs who do this work every day. We have hospital-based as well as healthcare-based infection control professionals and healthcare epidemiologists. We have wonderful laboratory technologists and pathologists that we can connect you with, and also other aspects of our hospitals: respiratory therapists, spiritual care, life care, healthcare administrators, all the different support structures and other healthcare workers that are needed for this response. Also in response, and we did this during the last outbreak in Iowa, and we set up structures to do this for Ebola during this current outbreak, is we, in coordination with a designated respect, our ASPR colleagues or CDC colleagues, as well as local public health, NETEC will hold coordinating calls with healthcare facilities and healthcare workers that are active in the response. We'll facilitate connections between those responding healthcare workers and SMEs that do the same sort of work that they do in special pathogen care and do that work routinely. But please note, if you do call NETEC, and we do welcome those calls, we will always ask you first if you've contacted your local infection control and public health authorities. It is critical that these individuals and these teams are involved right from the beginning when you have a concern that a patient may have a special pathogen. Also, wonderfully proud of our special pathogens research network. We work with CDC, NIH, FDA, BARDA, many other authorities to ensure that NETEC's ongoing landscape assessment of available medical countermeasures are up to date. In this response, we have been finding those potential therapeutics that may be available, and I know there are some questions in the Q&A, and we'll get to those. We also ensure that NETEC's medical countermeasure protocols and NETEC's single IRB for deploying these protocols are ready to go at all the level 1 facilities if needed. We, as mentioned by my colleague Dr. Knust earlier, we have been updating and sending out information about the Ebola vaccine that's available. And we've also been working with our level 1 respects to make sure they have ability to provide the Ebola vaccine to those that are deploying to the DRC, EMS and frontline facilities or healthcare workers here in the US, and then also, if needed, for high-level isolation unit healthcare workers. So just to summarize, NETEC and respects are working together for this response and all special pathogen responses to take available guidance and data and apply them in the context of individual healthcare facilities in the United States. NETEC and the respects provide just-in-time training and assessment tools to quickly prepare these facilities to respond to things like Ebola, viral hemorrhagic fevers, and other novel high-consequence infectious diseases. NETEC provides a cadre of healthcare workers with experience in care of patients with high consequence infectious diseases to support our U.S. healthcare workers to safely care for these patients. And working together with our wonderful partners in public health and EMS, NETEC is coordinating the NSPS, an agile, comprehensive special pathogen system of care network dedicated to protecting our patients, our communities, and very importantly, our healthcare workforce here in the United States. So we encourage everyone to join us in this response and join our public health partners. I will just emphasize something that hopefully you've heard about, but thanks to the wonderful coordination and advocacy of our partners in ASPR, we are able to stand up the STAND Award to bring in more partners as level 2 facilities. So we have an application deadline of December 2nd, but we'll be able to award $500,000 to up to 75 facilities around the country to stand up their preparedness and join us in the NSPS. If you want to learn more, please contact your local RESPECT. Feel free to reach out to us at NETEC, and please explore all the resources that we have on our NSPS and NETEC websites. Okay, I'll turn it back over to Dr. Mukherjee.
Wonderful. Well, thank you, Dr. Mehta. Very informative, and I learned a lot. So thank you. Thank you. The next part of our webinar is when we will reach out to our absolutely phenomenal lineup of panelists here and ask them some of the questions that have been pre-submitted prior to the webinar, some of the really good questions that have been submitted over the last 47 minutes or so. Just briefly introducing our panelists, we have Jennifer Hanna, who is ASPR's Director of the Office of Healthcare Readiness. Thank you, Jennifer, for joining. From the NETEC side, we have Vicky Herrera, our NETEC's Lab Work Group Chair. We also have Dr. Sharon Carrasco, the Director of Education and Training for NETEC. From the CDC side, we are joined by Joel Montgomery, who is the Chief of the Viral Special Pathogens Branch, by Brian Christensen, the Associate Director of Preparedness of Response in the Division of High Consequence Pathogens and Pathology. We have Nancy Cornish, who is the Medical Officer at the CDC and is a world-renowned lab expert, and Shahrukh Rohi, who is Senior Advisor and will help answer any travel questions that might come in. So thank you, panelists, for joining, and look forward to learning from you a lot, I guess. The first question, Sharon, I will ask you because it's come up in a big way. When you have a response like this threatening U.S. security and healthcare workers, what can NETEC offer in terms of training, frontline staff, IPC folks, lab training? If you could just take us through the training resources that you lead at NETEC. Over.
Yeah, happy to do that. Thank you, Vikram, and thank you for that question. So during a response, NETEC really does try to push forward resources that we have already created, but our goal is to make them more available and accessible to you all as participants. So we will, I think Dr. Mehta showed us several of our exhibit pages is what we call them. So they're landing pages for specific outbreaks. So we have the Ebola outbreak. We have that landing page available now with the most up-to-date resources available to help prepare healthcare workers. So things that should be implemented, things that frontline staff should be doing. We also, like this webinar, we do webinars to highlight the outbreak and really highlight the resources that we have available. And we do situation reports, which are about 2-minute videos that we push out on social media just to update folks on what the current situation is, what the outbreak is about, and what are the top 3 things people should know about that outbreak. So I think those are really the 3 big areas that we'd like to focus on during an outbreak. Of course, there is this just-in-time. I saw that question come up. There is just-in-time training and learning available, but our hope is that everybody already has these things implemented, that we do have training already in place. I think Dr. Fagan was saying earlier about the identify, isolate, inform process. That is key. That is something that we should not be doing just in time. That is something that we should be doing every day. And those frontline healthcare workers who are going to be potentially exposed and have to implement those protocols should be trained on those consistently. Back to you, Vikram.
Thank you. Perfect, Sharon. Thank you so much. The next question that's come up a lot is about testing, both at front lines, at Respects, and at the CDC itself. So maybe Vicky and Nancy, I'll hand it over to you. Could you describe if a hospital or a Respect has a suspect patient, a PUI, what capabilities are at the Respects, and how do we do confirmatory testing at the CDC? I'll start with you, Vicky, and then hand it over to Nancy to comment on the CDC's side of things. Thank you.
Great, thank you. The first thing to do is make sure you reach out to your public health lab. Know who your LRN laboratory is in your region. If they have the testing available, they can do that testing for you in consultation with the CDC. And then it would get sent to the CDC for confirmation. If the LRN laboratory does not have that specific capability, they can be in contact with the Respect laboratory. It is possible that they might have the capability there. And again, it would still be in consultation with the CDC, sending confirmation samples to the CDC. And I'll turn it over to Nancy to talk about the CDC.
Yeah, I agree with Vicky. The specimens should be sent to the LRN. And I think prior to anything happening with a patient showing up here in the United States, the state and the Respect facilities ought to be coordinating with their public health laboratory and their community hospitals so that everybody knows what to do if something happens. So anything else, Vicky, that we'd want to mention?
I think that pretty much covers it, but if there's more questions, I'm happy to answer.
Yeah, this is Joel Montgomery from Viral Special Pathogens. It's just to add on too for the confirmatory testing. Again, I think if we're talking about a VHF, we'd likely be using the BioFire Global Fever Special Pathogens panels in the Respect and LRN for ruling out VHFs. And if there is a suspect, presumptive positive or negative, those can come to CDC for confirmatory testing with our in-house PCR assays for it to be validated. And again, that's during the whole clinical consultation process, which Barbara covered in her presentation.
Well, thank you, Joel, and thank you, Nancy and Vicky. Appreciate that. A question from that was submitted before this webinar is, what is the current risk level for facilities in the US? Should we be screening patients at points of entry to the US? So Shahrukh, maybe I'll hand this over to you for thoughts about airport screening and what the threat levels are. Over.
Thank you so much. This is Shahrukh. I'm with the Global Migration team here at CDC. I saw a few questions about travel. That's always a topic of interest. So let me just start out by saying, in response to some of the questions, there are no travel restrictions from the United States. We are not discouraging people from traveling to the DRC, but we are asking people to watch their health during travel and watch for those signs and symptoms and consult a healthcare provider during and after travel. So that's I wanted to clarify that. Second thing is, we are not recommending entry screening into the United States at this time. DRC is currently doing exit screening in the outbreak area. As was mentioned by the presenters earlier, the outbreak area is quite remote and very difficult to get to. The Ministry of Health there has established some points of control and is doing some exit screening that has been going on for some time now. In terms of doing screening at this time, we do not recommend it. As was mentioned, there is a vaccine available for this particular strain of Ebola. And this is not as we say, the first rodeo for DRC. This is their 16th outbreak, and I think they have some policies and procedures in place. So we're closely watching this outbreak, and we will titrate our border health recommendations as needed. I hope that answers your question. Over.
It does. Thank you, Shahrukh, and thank you for such a in-depth review. A lot of questions being submitted. Anisha, I'll put you on the spot there about medical countermeasures, both for how you would initiate treatment for a person who's awaiting confirmatory testing. And once a patient has been confirmed, is there a role for remdesivir? Where do antibodies play a role? And so on. So over to you, Anish. Thank you.
Yeah, thank you for that question. I'll start out by saying the foundation of care for patients with Ebola and any viral hemorrhagic fever and any severe infectious disease is data-driven, goal-directed supportive care. And so having all the pieces in place to support your patient through their severe illness are the things that are most likely to deliver a good outcome for your patient. And that includes having a trained team and having that team, nurses, physicians, laboratory workers, all feel comfortable in the work and feel secure in the work that they're doing so they can deliver that high-level patient care. When we look from building from that great supportive care, there are, for this particular strain of Ebola, therapeutic options that have been proven effective. So my colleagues from CDC mentioned two antibody cocktails that we have been tested in clinical trials. And we do have availability of those in the United States. They may take a little time, but not a lot of time, given our great support from public health and FDA to get these in place. We do, with our level 1 facilities, we do have protocols to deliver them, but we also support other facilities, and if they don't have local support, how to contact the FDA with public health to get EINDs for these additional items. There was the one question about remdesivir. So I'll be clear that remdesivir is not FDA approved for the treatment of Ebola virus disease or any hemorrhagic fever at this time. It is used in some facilities while waiting for, if they don't have any availability of monoclonal antibodies that are directed at that pathogen. I would say that on a case-by-case basis, you could consider using remdesivir, but I would say that that would need to be in discussion with NETEC and CDC clinical consultation. It is available in most hospitals in the United States. We do know that it's overall safe, at least in patients infected with COVID, and it may have some ability to control virus. So it could be considered on a case-by-case basis, but it is not approved in the United States for Ebola viral disease.
Perfect. Well, thank you, Anish. Appreciate that. I guess we have time for one more question, and I'll open it up to anyone who wants to answer this. What kind of plans have been made to transport patients who are physically remote from their treatment centers? We know that we just have 13 level 1, NSPS level 1/respects across the country, though with Jennifer's guidance, we are hopeful to get 75 more very soon. But in the meantime, what kind of plans do we have in place to move patients from a frontline facility to respect and so on? I'll open it up to anyone, and maybe Anish, you and I can take that if there aren't any other thoughts.
Okay, well, I'll jump in while we're waiting. So one of the great things that ASPR and our public health colleagues in our state and jurisdictional public health agencies have really worked on are local, state, and regional CONOPs. And in these CONOPs, there are plans to move patients safely and effectively and quickly from a place where the suspect case is or confirmed case is to a place that can adequately care for that individual. There's also support structures for the facility that's waiting for that transport. There's support structures for EMS teams that are responding. But I think what we've seen over the last 2-3 years as we've really rolled out the NSPS is this wonderful reinvigoration of that CONOPS process at many of the states in all of our regions. And we really encourage those processes to occur. But critical to that is engagement with our EMS agencies to make sure that they have adequate training and are adequately included in the development of those CONOPs. And we're seeing that, I think, in very robust fashion over the last year. I'll turn it over to other colleagues to add.
Thank you, Anish. And thank you much. And I think that's even more relevant as we have the FIFA World Cup coming up in summer of 26, where patients and lots of movement across state jurisdiction borders will happen. So we're at 4 o'clock. Thank you all. Just a couple of closing remarks. One, I just want to thank ASPR CDC and our wonderful organizational team, staffed by Jason, Benjamin, Britton, Veronica, and everyone else who was able to make this happen. So thank you, everybody, for this close collaboration and a quick lift to deliver this webinar. I hope this was useful to everyone who attended. Of note, NETEC is here to help along with the CDC. NETEC will continue to build resources, develop education, and deliver technical training. If you have any questions at all, this is how you can reach us at info@netec.org. And if you need technical assistances, want a virtual consult or an in-person team, please email us at netec.org as well. Next, please. And then just sharing a few resources here that we have under Sharon's guidance, a lot of resources available for free. NETEC e-learning centers, podcasts, skill videos, all of these are here on this slide and will be sent over to you in a week or so over email as well. We're going to wrap this up here. Thank you all for the time, and I hope this was useful. Stay safe and have a wonderful weekend. Bye-bye.